common neonatal conditions that flummox us when we look after our small babies. And I'm not necessarily going to go into detail about those particular conditions because I think each of them are a talk on their own. But what we're going to really talk about is what we know about what affects the outcomes in these conditions, and also what are some of the long-term implications for the babies if they contract one of these conditions. But what we'll also spend a little bit of time talking about is some of the prognostic uncertainty that we have when we deal with these conditions, and how we actually deal with that prognostic uncertainty, how we might be able to think about dealing with that. Please do feel free to sort of pop questions in as we go along, and at the end, I think we'll try and spend a decent amount of time answering questions and talking about these things, because I think that makes it a lot richer than just me didactically talking about these things. So let's talk a little bit about NEC to start off with. I think it's certainly one of the more feared conditions for most neonatologists to look after extremely preterm babies. The incidence is reported as somewhere between sort of 1 and 3 in 1,000 live births. It all depends on how you stratify it and what sort of gestations you're talking about. If you look purely at babies under 32 weeks gestation, then that actually goes to about 5% of babies under 32 weeks gestation, and it's very much concentrated into those extremely low birth weight babies that we look after. I think what's really important to recognize, both in terms of treatment, but also in terms of understanding some of the short and long-term outcomes, is that NEC is it isn't one condition, and is often very difficult to differentiate from spontaneous intestinal perforation. There might even be somewhat of an overlap between these conditions. And I've got a graphic there which sort of shows you some of the different mechanisms that we think might cause NEC. So there's certainly some thought about bacterial overgrowth, altered colonization. There's certainly been some evidence in papers that have looked at 16S in stool of extremely preterm babies and found certain differences in the bowel bacterial composition of babies who develop NEC versus those babies that don't develop NEC. And certainly there is increasing understanding about the role of the bowel enteric nervous system and its recognition of different bacteria and how that might feed into the brain as well, and brain development. So the gut and the brain are quite intrinsically linked, and some of what we see in the long-term outcomes might be related to this as well. And certainly there are some factors that affect bacterial overgrowth, maternal chorioamnionitis, the use of H2 blockers, and of course the fact that we tend to use antibiotics, sometimes with indiscretion on neonatal units. So all of those things can affect the bacterial composition of your neonatal gut. Then we have what might be ischemic, osmotic, and other sort of infectious injury to the bowel wall itself. And again, there are a number of different mechanisms that are thought that might contribute towards this: placental insufficiency, the use of certain medications like indomethacin, polycythemia, blood transfusions, formula milk, fortifiers, and certain infectious agents such as cytomegalovirus, which I think we're increasingly starting to find when we look for it in babies who've had NEC or other gut problems. And this might be a direct injury to the bowel, or it may be that other mechanisms cause injury to the bowel that may allow bacteria or viruses to proliferate. And then I think there is the inflammatory response, which I think we all know has got a significant role in a number of neonatal conditions. And certainly with NEC, a lot of what you see both acutely and long-term is related to some of the inflammatory responses that we see. And there's increasing amounts of work looking at a whole range of inflammatory mediators that might affect it. So that sort of helps us to understand some of the pathophysiology of NEC, and that it is multifactorial. And of course, that then sort of feeds into some of the outcomes that we see as well. The other important factor with NEC is that we do now have improved survival for extremely preterm babies. And as we'll see with both NEC, intraventricular hemorrhage, and bronchopulmonary dysplasia, that increased survival comes with increasing morbidity. And there's the Swedish experience of looking at population-based data over a number of years from the 1980s onwards, has shown that over time, if you just look at NEC alone, in the 80s and 90s, NEC was often seen with a median age of around 32 weeks. But more recently, that median age has come down to about 28 weeks. And when they look at the population cohort, they find that there's almost 3 times as many babies who are born under 750 grams. So I don't think that reflects a fact that there are more babies being born prematurely. I think what it shows is that these children are surviving, and we are offering interventions to much more smaller babies than we used to in the past. And so, of course, we see some of this morbidity coming along. Similarly, things like spontaneous intestinal perforation may also be more common in somewhat smaller babies, and have often very similar care, which makes it very difficult to differentiate between NEC when you look at the outcomes information. And then, of course, the outcome itself is influenced by treatment of the NEC, such as surgery, sepsis, intestinal failure. We'll go into some of those in a little bit more detail. And then lastly, the long-term outcomes are often quite difficult to quantify more precisely. And the reason for this, of course, is that in many of the earlier studies and many of the earlier work that has been done, survival tended to be the greatest interest. And now, as we start having more children surviving, we start looking at some of the information on neurological outcomes. And it's only more recently that I think in every single kind of neonatal condition, including some of the surgical conditions, the neurological outcomes are becoming more and more recognized as being an important feature to have as an outcome measure. In the past, outcome measures tended to be much more short-term as well. So that means that there's a little bit of a paucity of data in terms of the longer-term outcomes from a neurological perspective. So let's have a look initially at the short-term outcomes. And I've got a paper here that looks at some of the UK outcomes from surgical units that have looked after babies with NEC. It's not actually very dissimilar to some of the other high-income countries that have reported data for neonates with NEC. So in Allen's study, what they showed was that when you looked at about 230 odd infants who had NEC, there's a bit of sort of variation in terms of how children are managed. There was a small number of children who had no intervention. There was about 10% of babies who had an intra-abdominal drain, some of whom then went on to have a laparotomy. But in the UK, the vast majority of children, 95% or so, who had significant NEC, went on to have laparotomy. This is a slightly biased population group because it is very much surgical data reported by surgical consultants. And so it fails to recognize some of the non-surgical intervention that babies have. But certainly, if you look at the surgical treatment that is offered in the UK, there is some variation between this and some of the data that is reported from countries like the US, where the use of intra-abdominal drains is often at a slightly higher percentage than is shown in the UK. But certainly my experience of having had varying surgical consultants with different approaches to this is the intra-abdominal drain is, once you have perforation, is very much a temporizing measure. Its only real utility is often in children who are too unstable, too unsick to have surgery. And so you use an intra-abdominal drain to temporize them until such time as they're stable enough for surgery. It's not a treatment modality on its own in the majority of children. But I think some of the US teams do have slightly different experience of this. But when you look at the children who had laparotomies, a very small number had a negative laparotomy. Some of those cases were subsequently reported as spontaneous intestinal perforations. The majority would have had resection and stoma formation, although some would have had just a stoma formation, some would have just had a primary anastomosis. And then there's a small number whose illness was considered severe enough that they couldn't have a stoma or anastomosis, and they would have what is sometimes called a clip and drop, which is where you clip off multiple segments of bowel that is healthy, resect the bits that are unhealthy in between, and then leave it behind to come back another day. And about 5% would have had such significant disease that you'd realize you can't do anything, and you would close without any further intervention. And so when you look at that cohort of children, once you look at sort of what percentage of those children have those sort of death, of the entire cohort, about 1 in 5 die within 28 days. And this is particularly so in children who have laparotomy confirmed NEC, but also actually quite an interesting number of children who have SIP actually end up dying within 28 days as well. And of course, as you'd expect, the children who didn't undergo laparotomy had a better chance of survival if they didn't have other complications. But in this particular study of children who didn't have a laparotomy, they seem to suggest that there's a higher proportion that died within 28 days. And I suspect that reflects that you had children who had perforations who were very sick and were not suitable for surgery, and that's why they didn't end up having their surgery. If you looked at the number of children who were alive and parenteral nutrition free at 28 days, if you ended up not having a laparotomy and managed to survive beyond 28 days, then you didn't actually need the PN. You often managed to feed by that point. And you can see here that a significant proportion of children actually still needed PN at 28 days if they had confirmed NEC and perforation. And very few children actually managed to go home within 28 days if they had perforation. For those who don't know what a Clavien-Dindo grade is, it's a way of grading surgical complications post-op. Grade 1 is relatively minor complications such as needing some additional medication, pain relief, etc. Grade 2 is things like needing parenteral nutrition, may need more specific medication. Grade 3 and 4 are varying degrees of surgical management afterwards. And again, the percentages are probably not quite as important as recognizing that quite a significant proportion of children who have surgery end up having complications. And this is quite important for us to counsel our parents about, to say that surgery isn't really sort of going to be do the surgery, child will recover afterwards. Significant numbers of children go on to have complications following their surgery as well. So if you take all of that into context, the mortality from NEC, about 25% of children with confirmed NEC go on to die within sort of 28 days, or certainly before they discharge from hospital. And when you look at extremely low birth weight babies with surgical NEC, so NEC with perforation or requiring surgery, the mortality can go up to about 50%. So that's quite a significant number. But what isn't always recognized is that late mortality is also an important feature of NEC. And in some studies, especially those with surgical NEC in extremely low birth weight babies, this percentage can go up to about 30% of babies having late mortality. In terms of the longer term outcomes, this is quite dogged by the fact that there is a lack of uniformity in how you define poor neurological outcomes. Typically, you define it as severe if you've got a PDI or an MDI less than 70, but a number of studies use composites of MDI, PDI, severe hearing, and visual impairment. And so Prof. Piero from Manchester, as well as others, produced a paper not too long ago, 2007 or so. I don't think it's changed substantially since then, which tried to sort of quantify what these outcomes were like. And what they showed is that if you were a preterm baby and you had NEC, you had a worse outcome than if you didn't have NEC. That's quite, I think, self-explanatory. What they also showed is that if you had surgical NEC as opposed to medically managed NEC, again, your outcome was neurodevelopmental outcome tended to be poorer. And some of the American papers have also shown something very similar, which is that the neurodevelopmental outcomes are poorer, and that varies from between sort of 30 and 60% of babies with surgical NEC. And if you had surgery for any reason during that episode, the outcome from a neurological perspective tended to be poorer, especially so in the extreme preterms. What Piero then did also was then to have a look at a number of meta-analyses of various other studies. to look at specific neurodevelopmental markers such as cerebral palsy, visual impairment, etc. And what this table shows you again is that if you had NEC versus not having NEC, your cognitive and neurodevelopmental outcomes tended to be poorer, and there's a significance for neurodevelopmental impairment and cerebral palsy if you had NEC. And similarly, if you had surgical management of your NEC, again, you had some degree of neurodevelopmental impairment and cerebral palsy. For things like visual impairment, it may not have been quite as significant as one might have expected. And then I think from a quality of life perspective, and this is quite an important one, I think, because if you ask parents what affects them from a quality of life perspective, even in children who've got neurodevelopmental impairment by objective measures, and we'll come to this in IVH as well, parental reports of executive function, behavioral, and so on, tend to be less adverse than the objective measures. But when you ask parents what are the kind of things that particularly affect quality of life, this is often things like inability to feed, poor feeding, poor growth. And so intestinal failure, I think from an NEC perspective, is quite an important condition to consider. If you look at purely medically treated NEC, intestinal failure is rare, possibly less than 5%. Some reports are as low as 1%. But when you start looking at surgically treated NEC, it becomes far more common. And in some studies, it's reported to be as high as 40%, others around 30%. There is some variation in how intestinal failure is defined. A common definition seems to be a failure to achieve full feeds within 90 days, although some do use a definition of needing parenteral nutrition for more than 90 days as well. They're very similar in terms of what you're saying, but there are subtle differences in how you might calculate that. And again, what Nigel Hall from Southampton showed in a systematic review published last year is that if you looked at just purely looking at Bell stages 1 to 3, so including the more milder versions of NEC, intestinal failure is only present in about 15% of children. But if you look at the studies which looked purely at surgical NEC, then that rate goes up to 20 to 30%. And if you then sort of subdivide this into different groups, what you tend to find is that the younger children and who are much smaller at birth tend to have a greater incidence of intestinal failure. If you have severe instability at the time of diagnosis, so children that need to be intubated at the time of diagnosis, children who have significantly lower albumins, needing inotropes, etc., those tend to have a higher rate of intestinal failure. The other thing that I found quite interesting in a fairly large paper from, I think it was China, and I think this is reflected in our own experience at St. George's as well, where you have smaller, younger babies who get through the first week or two without developing NEC, and then develop what we call sort of late NEC that presents in that sort of second peak of NEC, somewhere around 4 to 6 weeks of life. Those children tend to have a much higher rate of intestinal failure and a much more complex stay than those children who have NEC in that sort of first week of life. So that older age at diagnosis tends to have a poorer outcome in terms of intestinal failure. And the last one, which I think is again sort of something that you'd expect, the more bowel you have resected, the more likely you are to have intestinal failure. And the length of bowel that you need resected to increase your risk of intestinal failure to closer to 50% is not as large as you might think. Children who didn't have intestinal failure, typically bowel resections tended to be in the 1 to 2 centimeter range. If you had bowel resection that exceeded 10 to 12 centimeters, then your rate of intestinal failure seemed to approach around 50% or so. And then again, as you would expect, although it didn't quite reach statistical significance in most of the studies, if you had a multifocal NEC, there was also a higher rate of intestinal failure. So I'm going to stop there in terms of NEC and its outcomes. I think in summary, what I would say is I think the mechanism of illness in NEC tends to have a significant impact in terms of your long-term outcomes. And my own experience seems to be that the children who are relatively stable, who don't have a significant inflammatory response to their NEC, do seem to do more well long-term, both in terms of neurodevelopmental, but also your shorter-term outcomes, such as your liver failure and your intestinal failure. But the more significant inflammatory response you have, the more significant instability you have from an inflammatory perspective, those children tend to have more cholestasis, conjugated biliary hyperbilirubinemia, liver dysfunction, and also intestinal failure. So I'm going to pause at this point for you to ask any questions that you might have around NEC before we move on to bronchopulmonary dysplasia. And I see there's a question here from Yasser. And the question is, are there any gestational cutoffs or weight below which your surgical colleagues won't operate? I think the simple answer to that is no, we don't. Those of you who live in the UK might remember a newspaper article a year or two ago of an extremely small baby. I think it was about 600 odd grams or 500 odd grams, who was operated on for NEC, had multiple transfusions intraoperatively and post-op, and who went on to survive. So there isn't necessarily a gestational or weight cutoff, but there is certainly a greater degree of multidisciplinary discussion around some of the extremely growth-restricted babies who have significant instability pre-op, with a view that these are not decisions that surgeons make on their own, but the surgical team very much work with the anesthetists and the neonatal team to try and decide which children should be operated on and which you don't operate on. And the way that we operate at St. George's is very much in that sort of multidisciplinary discussion with no one team particularly sort of taking the responsibility for making the decision to operate. I hope that helps to answer your question, Yasser. Any other questions around NEC before we move on?
So there's a question from Santan, who is one of our MTI trainees. And the question that he's got is, a lot of people make a diagnosis of NEC within the first 2 weeks of life. And that is, the more preterm you are, I think he's kind of alluding to the fact that you should develop symptoms late. Now, the question is that NEC, or is that something else? Or is that a spectrum of NEC? And the other question he had was, I mean, clearly the differentiation between SIP and NEC and outcomes, that's not very well differentiated. So for your local data, are you considering them separate entities or the same entity?
Okay, two very good questions. I think the first question, Santan, is because NEC, I think, is a multifactorial, multidimensional illness, with possibly some being more of a infective process, some being more purely inflammatory, some being more vascular. It's very possible that you're dealing with different mechanisms of injury producing a similar clinical picture at different points, and that's why you have that sort of multimodal distribution in terms of the incidence. And we certainly do see that there's a group of children who have a presentation that we would call NEC because of how it presents in terms of abdominal features, X-ray features, etc., which tends to sort of peak in that first week of life, which I think we would still call NEC. And then a somewhat different presentation, but with very similar radiological and clinical manifestations, which tends to arise somewhere around the sort of 4th to 6th week of life. And I think they're both still this condition that we call NEC, but the reason why those children get the illness in those two periods may be somewhat different, and that may well have a difference in terms of outcome. And again, as I said before, my experience has been that it's that later NEC that tends to be often somewhat more fulminant, more rapidly progressive, and the ones that tend to have a poorer, longer-term outcome. In terms of your second question, which I think was around SIP and NEC and the differentiation between the two, I think it's quite difficult. We've certainly had children who clinically have looked more like an SIP, who have an incidental presentation where you do an X-ray for some other reason and you find, well, hang on, there's perforation here. You can see gas in the free gas in the abdomen. the child is relatively stable from a physiological perspective. Sometimes they're not even intubated. As I said, can sometimes be an incidental finding. But we have been surprised even in some of those children where at operation, the surgeon has felt actually this looked more like NEC than it did SIP. And the reverse has happened where we've clinically thought, gosh, this looks very much like NEC. Abdomen is shiny, red, distended. There's more clinical instability than you would have expected with an SIP. But actually, when the surgeon goes to theater, they go, well, actually, the bowel itself, the rest of it looked fine. This looks very much like a blowout kind of lesion with SIP. The location is correct for SIP, but the child may be more unwell. And what you find in a lot of the papers is that conundrum in terms of the diagnostic features, but also the surgical features, mean that it's very difficult to clearly separate out your SIP patients from your NEC patients. So when it comes to our outcomes, where it is absolutely clear, both clinically and surgically, there is a spontaneous intestinal perforation, we record it as such, and we don't consider that as part of our NEC outcomes. But where there's more uncertainty, we tend to sort of say it's suspected NEC, and we tend to consider those as part of our NEC outcomes. And it is challenging, and we have a Friday morning surgical MDT where the surgeons and the neonatologists sit down together to have a chat, and also not common. There are times when there are some spirited discussions as to whether this was NEC or whether this was spontaneous intestinal perforation. As you'd expect, the surgeons often win because they tend to be louder.
Sijo, just one other question that we've got, and this is from Savitri, who is working in Jaipur in India. So probiotics a lot of places like Canada using it routinely. Have you implemented it or thought about it? And I mean, the question is obviously when and how.
I think that's a very good question. I would add a third one to it, besides the when and how, a third, which is what. Probiotics, much like NEC, is not a single product. It's not like ibuprofen, where you can say, well, this is ibuprofen and this is indomethacin. There is a lot of uncertainty as to which bacterial strains may produce benefit. I think that one of the larger and better studies that have looked at this was the PIPS study, which used a specific strain of Bifidobacterium. Very large, very well conducted study. And despite that it being a very well conducted study, I think there was still some cross contamination between children who were on the control arm and children who were in the intervention arm. A number of the other studies that have looked at probiotics have been have had significant issues with cross contamination on neonatal units, with the control groups also getting a degree of the probiotic bacteria. The PIP study showed absolutely conclusively that that particular strain of bacteria provided no benefit in terms of NEC and provided no benefit in terms of late onset sepsis. Of course, a number of meta-analyses more recently have shown that there is some benefit from probiotics, and specifically certain lactobacillus strains. I have to say I'm still somewhat unconvinced, and I'm unconvinced because I think the meta-analysis, although the meta-analysis itself was very good, a number of the studies that were included had significant issues, both in terms of bias, but also in terms of contamination, or did not look at contamination as a outcome as well. So for that reason, we've gone backwards and forwards on the probiotic issue for a number of years, and we've not implemented probiotics as a routine of care. However, more recently, we've looked at a particular product which one of my colleagues is quite keen on, which is a particular strain of lactobacillus, I think, which seems to suggest there is some benefit. And I think we are in the process of speaking to our pharmacy and our medicines board to approve its use, because it's not an approved drug as such. It's fairly expensive. I think this particular preparation, I think we've estimated if we were to use it for all our high-risk group of children, will cost us somewhere in the region of 10 to 20,000 pounds per year. So that's that's not cheap at all, even for the UK. But we've as a consultant team agreed to start its use because I think we're fairly convinced that even if it doesn't provide any benefit, it doesn't produce any harm to children. And considering how devastating a condition this is, even if there is some marginal benefit, it may be worth trying. But we're going to be implementing it while at the same time looking at our NEC and other condition incidences over the period pre and post implementation to see whether we can see a difference. And I suspect we would need to use it for 5 to 8 years at least for us to be able to start seeing any difference. So that's where we are with probiotics. I don't think the story on probiotics is that clear in terms of benefit, but I do think that all the evidence does show that it doesn't cause any harm if you use appropriately prepared preparations of probiotics.